Welcome to the 3030 Health Podcast. The following discussion is for education and entertainment. It is not intended to diagnose or treat disease. Please do not apply any of this information without first discussing it with your doctor. Here is your host, Dr. Ruiz.
Hello, everyone. Super excited to be here with three of my friends. And this show is super special to me because about a year ago, after I graduated, I decided to do a thing called the Future of Naturopathic Medicine. And I wanted to highlight some of the people that graduated with me and were doing some awesome stuff within the naturopathic community. And I want to keep that tradition going. And I have three people that just graduated from my school, the Southwest College of Naturopathic Medicine. And I want to introduce them to you. So without further ado, I have Dr. Tiffany Turner, Dr. Billy Mitchell, and Dr. Morgan Mastingale here with me this evening, and we're going to talk about what is the future of naturopathic medicine. But as it is customary in my podcast, we're going to start with hero stories. So we're going to start with Billy because everyone's too shy to start with their hero story. So Dr. Mitchell, who's been on my show before, Dr. Mitchell, what's your hero story?
Man, well, I'm kind of shy too, but the way I've been answering this question is it's sort of twofold. So it wasn't entirely out of altruism. I think a lot of folks get into medicine because they want to help other people, and it's certainly cool to do that. And it's nice to feel all warm and fuzzy inside when you help out a patient or educate them or make them feel better. But really, the two things were my own suffering or walking the path of thorns or story with my health. And then just this desire to be like a detective of sorts, a medical detective. So I'll keep it pretty, I'll do the abbreviated version. So when I was a kid, I wasn't like too unhealthy, but I was always underweight. I had trouble with memory and paying attention and stuff like that. Nothing like severe, just minor tension type stuff. And I had chronic anemia and kind of a few pieces of what we call the atopic march. So eczema, not quite asthma, like half of asthma, exercise induced. And I managed to miss the rhinitis for whatever reason. And chronic anemia that got so bad at one point, I was told I had no iron in my body, which was pretty foolish, right? Because all of us doctors here know that if I had no iron in my body, that wouldn't be compatible with life. So anyway, it got that bad. And kind of the crux was an ulcer that perforated while I was a track and field athlete in college due to ibuprofen overuse. So all of these issues kind of waxed and waned. And then they were kind of amplified after I had this ulcer that perforated and the surgery that followed. So, I had my life saved by, acute care. But kind of the aftermath of that was kind of the resurfacing of a lot of these childhood issues. And some other ones that became more apparent to me then, which were kind of mood issues and even something really funky like Raynaud's, which I now have an appreciation for because of my interest in rheumatology, which we'll get into. But so anyway, I learned about the things that we teach our patients through, I think one of the first blogs I ever read was Chris Kresser's blog, and, learned about the paleo diet and circadian rhythms and environmental toxicants and all that stuff. And all these different levers that you could pull in getting somebody to a better place with their health. And so I figured out which ones moved the needle most for me. And it seemed to be toxicant burden and nutrition. And that really took me to a different level. And so I just thought it was really cool that, we could flip a lot of our issues on and off like a light switch, right? Epigenetics and environmental inputs. And I just wanted to learn how to share that with people, which I kind of got a push from through a part-time job I worked at Sprouts. People would come in with lab values and stuff and be like, hey, can you look at these? And I was like, no, because I have no idea what the hell I'm looking at. And I would be doing you a big disservice. And after this continued to happen more frequently, I was just like, man, this is like the universe telling me that I got to do something more here. And so my greatest mentor, Mitchell Hopkins, who was a chiropractor planted the idea of naturopathic medicine in my mind. And I looked up the schools that we have in North America, and I looked up the one closest to home with the best clinical program, and that was Southwest College of Naturopathic Medicine. And I applied and made it through, and now here I am.
Awesome. It's very inspiring, because if you are in this health journey and if for some reason you're listening to this podcast, it starts with you. And we all have very different stories, but like the content of the narrative is the same. It's, you either were looking for answers for a loved one or you were looking for answers for yourself, because you are your own advocate, and because of education and because of curiosity, you end up changing your life and hopefully affecting the lives of many people. Dr. Turner, what's your hero story?
You mentioned us being too shy to share it, but I think partly it's just that it's so complicated. It's so hard to put into, just a few words.
Into 5.2 minutes. You have 5.2 minutes
Thank
to
you.
tell
I
me.
like that definite answer. I'm going to watch the clock.
Yeah, so you can tell me your whole life story.
Oh boy. Wow. Okay. I've had a really short life apparently, but I went through a bit of a torturous route to get to where I'm at. I initially started off wanting to do something completely different. I didn't even take biology in high school. I avoided dissections and all gooey things at all costs. And then I just started questioning things around me and seeing loved ones, like you said, either kind of not get the solutions they need or kind of be struggling. And I think the last straw was when I lost my cousin. And at that point, I realized I wanted to do something different. I had a complete change in perspective on life in general and how I live my life. And I decided I want to do a complete kind of 360 from where I was at going into software engineering and change that and go into the field of medicine. And since then, I've just really been committed to seeing how I can help people become, their best selves and their healthiest selves so that they can go out and live the life that they've wanted to and fulfill those dreams that maybe they had even as children. And just looking around me and seeing all these people and having this idea that, what if all of these people had the ability and the health to pursue those dreams, and how can I help them do that, and what would our society look like in that case? And that's kind of the short story of the long story.
And interestingly, is when we want to help people, I don't know if this is your same experience, but you just, you want to teach them how to fish. You just don't want to give them fish, and you're trying to find answers that are more intricate and sometimes a little bit more nuanced than just giving them a prescription or putting a Band-Aid. We're like trying to seriously look for the underlying cause of disease. And that makes it so much more satisfying. And where are you working or what position are you holding right now?
Well, I'm currently a first-year resident at Integrative Health in Scottsdale, Arizona. I am not a chief resident. I am a first-year resident, which means I am brand new. It's very exciting. We have a ton of fun there. I think, it's maybe not even legal how much fun we have, but that's okay. We have a lot of fun.
And I've heard through the grapevine that you have a great mentor.
Oh, yes. That's Dr. Alan Christensen.
Oh, I was referring to myself.
Oh, no, Dr. Alan Christensen is pretty awesome, and I think you would actually agree with that.
We have many great mentors.
I consider you a partner in crime. That's a little different than a mentor. We just go get into trouble and dig up bugs in the lab and things like that. So
yeah, no, and we have great mentors. Dr. Paul Midman, Dr. Alan Christensen, Dr. Jeffrey Langland. Just like such amazing people, and we wouldn't be here right now if it weren't for them.
Yeah, we're pretty lucky, but we also worked really hard.
Dr. Massingdale, what is your hero story?
Well, unlike Dr. Turner, I actually knew I wanted to be in the medical field starting in the 8th grade. First time I dissected a frog, I was sold. I was so into it. I wanted to know why the body worked and why sometimes it didn't work. I went through undergrad with that pursuit, and I really thought I was going to go into allopathic medicine because that's really the only thing I'd experienced in my life. And I learned the hard way that what my grandmother told me as a child over again, that things happen when they're supposed to happen, is completely true. I did not get into medical school right out of undergrad, and it led me into pharmaceutical research. And so I did that for about 8 years after graduate school. And I ended up out here in Arizona working for a company that was doing third-party contracting with giant pharmaceutical companies. And I got super burnt out. I was just seeing all of these patients and going through and doing these intakes, and they're just overloaded with this polypharmacy because no one had bothered to manage their first condition with a little bit of counseling of diet and lifestyle. And, instead they just layered drug on top of drug on top of drug. And it was right around this time that I actually ran into Dr. Jordan Hoffman, who graduated from SCNM a couple years before I started there. We just randomly met, and he was like, "Oh, what do you do?" And I was given the patented pharmaceutical research, blah 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 blah. And he actually laughed at me, and I kind of was taken back a little bit, and I was like, "Why? What do you do?" And he told me about naturopathic medicine. 6 months later, I was enrolled at SCNM. So that further proof from my grandmother from the great beyond that things happen and you meet people when you're supposed to, and it kind of evolves in that way.
It's funny, how, like, I bet the conversation was like, I use science, research, and statistics to figure out what is the best way to bypass physiology.
Right?
And he was like, yeah, I just use nature and the way things are supposed to be done.
I just remove the obstacles that society puts in the way of our healing, and
Yeah.
our body's intelligence do the work.
It's so much more poetic and cost effective, and we forget that, we have all the resources, and we just have to look at our grandmas or our great grandmas and look at the things that we were doing that kept us alive. And maybe pharmaceuticals are necessary from time to time, but, you have an interest in a very specific modality, and you got a really prime residency. Can you talk a little bit about that?
Yeah, I was very fortunate to match as a first-year resident at the Pain Relief Center at the Southwest College of Naturopathic Medicine, soon to be the Neil Reardon Center for Regenerative Medicine. And I'm training with some great physicians, Dr. Van Dyke, Dr. Bethel, and Dr. Seenoth there, and just learning some great skills, mostly focused on injection therapies, which is super exciting to me, which is really harnessing the body's worker bee cells, extracting them, concentrating them down, and then injecting them back to do the work of healing, which is awesome.
A second ago, you mentioned, that you didn't want to do allopathic medicine, or that you were going on the allopathic track. For people that might not be familiar with this, can you explain the difference between what you do with your injection therapies and just like a compare and contrast how someone would treat maybe a frozen shoulder using allopathic medicine versus using our awesome naturopathic modalities?
Sure. One of the most common things I see walking to the office is actually knee pain. If you walked into a typical orthopedic office, because of the way the insurance game is played and what they're able to offer and the time that they have to spend with you, most likely you're going to walk out with some PT and maybe a corticosteroid injection into that joint, which will bring down the inflammation and it will decrease the pain.
Which is the allopathic. This is the allopathic puzzle.
Right.
So
right.
you have inflammation. Let's decrease inflammation.
Exactly. But it's really not addressing why that inflammation is there or promoting any healing of the joint in the long run. And that's a conversation I have to have with patients when they come in seeking, either stem cell therapy or PRP or traditional prolo. It's not going to be that instant pain gratification, but long term, you're going to see more healing of the ligaments, tendons, and of the actual joint, which, in the long run is going to be more beneficial for your continued activity, your continued health, and kind of pursuing the goals that you have.
So you're not injecting corticosteroids, and you mentioned
No.
you mentioned you inject PRP and Prolo. So what are these things doing in the joint?
So you start off with like a basic prolotherapy. You're using a diluted dextrose solution, which is sugar,
But
and you're
that's
basically
inflammatory.
creating. I know, and that's the point. Actually, you're creating targeted inflammation, which is drawing the body's immune system to that particular area to do the healing that maybe it didn't do after initial injury, because that structure is actually very poorly vascularized, meaning it doesn't get a whole lot of blood flow. And so, when we have sprains, strains, that sort of thing, they don't necessarily heal correctly, especially if we go with the old rice method of ice it until it's numb, which is pushing, blood flow away from the area. It does decrease pain immediately, but long term, again, we're looking for healing, and that's going to be dealing with a little bit of discomfort while you're promoting healing within the tissue. Kind of up from there, you have PRP, which is platelet-rich plasma, which is more indicated for kind of intra-articular injections. And you're actually taking the patient's own blood, spinning it down, and harvesting the layer where the platelets are and growth factors are most rich, and then injecting that either into the joint or again into the periarticular structures, being the ligaments, tendons, that sort of thing. Above that, we've got the stem cell therapies, which are kind of buzzworthy right now, especially as we're bringing the regenerative center into SENM. Currently in the US, we do not do any stem cell expansion. It's simply harvesting either bone marrow or adipose tissue, concentrating down where we believe those stem cells to be living, and injecting that straight back into the patient. We're excited to kind of apply for some FDA trials to start expanding and getting kind of better results there, but it's all in the future.
That's awesome. Billy, or Dr. Mitchell, you mentioned that you have an interest in rheumatology. What is this? So do you only treat rheumatoid arthritis? Where are you seeing patients? And how does your treatment differ from something that, when you go see a rheumatologist?
Yeah, so just so people know what rheumatology is, a lot of folks hear that term, they're like, what is that? Well, basically, it tends to be autoimmune musculoskeletal conditions, but there's a lot of other autoimmune diseases that fit under that umbrella that rheumatologists will try to treat. So Morgan talked about degenerative arthritis. We have a different category of arthritis that we refer to as inflammatory arthritis. So one that a lot of people have heard of is rheumatoid arthritis, but you've also got psoriatic arthritis, you've got lupus arthritis, and that's the fun in all this. It's really complex, and it's an internal medicine specialty that really focuses on what we do as naturopaths, which is look at the body as a whole, right? Basically, what you're going to get in kind of the allopathic realm is what we call, well, everybody knows about NSAIDs, right? So ibuprofen, naproxen, stuff like this that you get over the counter that you might take for headache or menstrual cramps or whatever. So you've got first line therapies, which are typically NSAIDs or what we call CSD-MARDs. So these are conventional synthetic disease modifying anti-rheumatic agents. They have names like Plaquenil, methotrexate, sulfasalazine. This is typically what you'll be started on, regardless of what rheumatologic condition you have. So NSAIDs are anti-inflammatories. The other ones are kind of immunomodulators, okay? And autoimmune conditions where your immune system is attacking your joints. So we're trying to modulate the immune system. And then the heavy hitters, kind of the newer kids on the block, are what we call biologic DMARDs, okay? And they're antibodies, basically. Our immune system makes antibodies to render certain pathogens and microbial proteins and things like this inert or harmless. And so we can harness that antibody ability to target signaling molecules that come from different players of our immune system. So these DMARDs they'll mess with the text messages that your immune system send out that causes the inflammatory process. So they target the text message or they target the inbox where the text message goes. The first line and second line therapies, the NSAIDs and the conventional DMARDs, are usually ineffective, and patients tend to respond pretty profoundly to the biologic DMARDs. The problem is, as fantastic as they are in symptomatic relief and reducing disease severity, there's pretty significant side effects. And the rheumatologists will say they're rare, but the statistics don't matter when it happens to you. And so you can end up hospitalized with infections, because again, these things are tinkering with your immune system and trying to arrest the inflammatory process that's destroying your joints or your organs, which we use for pathogen defense. And the other thing is increased risk for cancer. I've asked a lot of rheumatologists this question. They say they look at these huge registries of Taiwanese patients who've been on them for pretty long periods of time, and they'll be like, there doesn't appear to be cancer risk. In my opinion, I haven't finished reading all of the literature yet. The jury's still out. So increased risk for dramatic infections and increased risk for cancer. And then there's some other things that happen with the liver and lipids and stuff like that. But that's basically how it's approached in a conventional setting. Naturopathically, what we do is, as Morgan and Tiffany mentioned, is we remove obstacles to health. So a lot of lifestyle levers we sort of pull. A big one is diet. And there's a lot of new research coming out with an approach that I like called the autoimmune paleo protocol, or the autoimmune protocol. Terry Walls, who's an MD, who's an expert in MS, has something similar. Really important, getting diet in place. Fitness is kind of controversial, but for a lot of these autoinflammatory and autoimmune conditions, actually high intensity exercise is immune modulating, making sure the patient's sleeping. And then when these basic things are in place, all the, and there's other things I'm leaving out, like sunlight and de-stressing. When all that basic stuff is in place, then we want to ask, and this is something that conventional rheumatology doesn't do, we want to ask why the immune system is dysregulated. To them, the cause is the immune system. Let's modulate the immune system or screw up its signaling molecules with these drugs, and that's the end all be all. We induce remission with that, done. Well, we want to ask why. We want to go a layer back and ask why the immune system is dysregulated. And so then it gets into this complicated area where we look for these different etiologic factors. And you're into microbial research and stuff like that, and you're aware that a lot of these pathogenic agents are implicated in a lot of these rheumatologic conditions. A clear one is Klebsiella in ankylosing spondylitis. So, pathogens, environmental toxicants. Another one that's really big and underappreciated is emotional trauma. Micronutrient deficiencies, kind of a one that hasn't been substantiated too well, but is in a lot of animal models of autoimmunity. Actually, two are vitamin D, which we know about, but vitamin A, really important, those fat-soluble vitamins. So there's a lot of different etiologic factors, but that's what we try to do, rather than just give drugs, or a lot of rheumatologists will use turmeric now. That's kind of bled into their area, and they're like, "Well, turmeric." So we don't practice allopathically or greenly allopathically. We remove the obstacles to health, and then we really hone in on your story and try to figure out what the possible etiologic factors are to address.
And what comes to my mind is that even if you were using the DMARDs, even if you were using medications or pharmacological agents, why not fix the house? Why not get a good foundation? And now, if you must use this disease-modifying drugs, now your chances of getting cancer, now your chances of getting an infection are going to be lower.
Yeah, and that's an important point. So I mean, you're reducing those risk of those things by virtue of just getting yourself healthier. And I don't come down too hard on the pharmaceuticals, just because I've seen them, I've witnessed myself. They just do some amazing things. I mean, I've seen folks progress radiographically with the rheumatology specialists I've hung out. I've seen that happen in really short order. And so as a transient means of kind of quieting inflammation and preventing those potentially life-altering situations, I mean, It's huge. I mean, imagine if you're a piano player and you can't use your fingers anymore, you're a computer programmer, or you're an athlete, and these are things that you love to do. And so it's really good to have the whole armamentarium. But the proposition of using DMARDs and biologic DMARDs as a long-term solution is, in my opinion, not a good one.
And with this different lifestyle changes, like for example, maybe stop eating inflammatory foods like gluten or sugar or things like that. Maybe for someone that just wants to look hot in a bikini or hot without a shirt, that's like, well, maybe every once in a while you can have a beer. But for someone that is losing their joints, for someone that is, that maybe won't be able to hug their kids anymore, for someone with lupus that might need a liver transplant, you have to be a little bit more conscious about the decisions that you make. And having someone like you guiding those decisions and explaining why it's so necessary, it's just something that, this specialty needs.
Really, really important point there you brought up, and I don't want to be super, I don't even know what the right word is I'm looking for. I don't want to say there's room for no fun, but really,
like dogmatic. You don't want to be dogmatic.
Yeah, 80-20 really goes out the window with these kinds of patients. And I mean, it's really got to be 95-5 and all in, at least for some time, until we're again addressing those etiologic factors and making you more resilient. But I mean, just that lifestyle piece alone is going to get most people 80% of the way there. That's not just me as a newer clinician saying this. This rheumatology specialist I've met with, who's been doing this for over a decade, has seen this. I mean, he's got these patients who fail all of them, or the medications failed those patients. They learn about this through somebody else, and they come to him. And just over the years, he's observed this, and the results have been remarkable.
Good catch, Dr. Mitchell. People say, "Oh, this patient failed on this drug." No. This patient did not fail that drug. That drug failed that patient.
Correct.
That is the right frame of mind. And if you have autoimmune thyroid disease, if you have if you went on to surgery to get a joint fixed, that surgery or that thyroid replacement failed you if it wasn't the right answer for you. So you are not hopeless. You are not, you have to continue being an advocate and try to find, some young blood and some cool people like the ones I'm interviewing right now. Dr. Turner, you are right now on a fast track to become an endocrinology Jedi. Can you, what's the difference? What have you noticed, from like the way that you see, you have been shadowing for almost a year, since before school ended for you. You had been, shadowing doctors, and we spent how many hours with Dr. C and Dr. K, and, what have you noticed, in the different approach to endocrinology from like the patient that has tried 4 or 5 doctors and ends up in front of us versus the way that we approach these conditions?
So as far as the patients, we get a lot of patients who they really are an advocate for themselves. They've done their homework. So they come to us and they're already doing a lot of really good, healthy lifestyle things. They just need to kind of get their dose perfected, or maybe look into some areas that maybe they had overlooked, or maybe they didn't know to look at, or maybe do some more specific or specialty testing. And then where we come in is with our specialty, kind of focusing in on one area. We really help each other to stay on top of the latest research, and that allows us to help our patients better than we could if we were trying to do everything and then still give good care in the area of endocrinology. And so we spend hours and hours shadowing each other, hours and hours with Dr. Christensen. And we even have our own little integrative health university, which I think is super cool as someone who is a perpetual student and nerd, because we take time out to hang out with both the staff and the doctors and discuss the latest research, go through the way we do things, and discuss whether there's ways to do them better, and discuss patient feedback and where our patients think we're doing great and where they want more support from us. And we then work to collaborate on those points and really make the practice better and stronger.
So on your role, on your way to becoming a specialist, are you just treating thyroid, or are you just treating endocrinology disease?
So we see a variety of conditions, gastrointestinal conditions, we get some mood conditions, we get diabetes, really a wide range, but we do see a lot of thyroid. And that's, really what Dr. Christensen is known for. But it's the whole person we're treating. So it's not like we have a patient come in and they're a thyroid patient and we look at their thyroid labs and we adjust their dose of thyroid medication or methimazole or whatever it is they need. We really look at that whole patient and we look at their gut health and we look at heavy metal burden. We look at all sorts of specialty testing, their cortisol, their, all aspects of that person, their lifestyle. We have Dr. Kashaba, who's a big fan of micro workouts, and she'll pick up something heavy in the room and show the patient, this is how you squat, or this is how you do lunges, this is how you use little weights to increase your bone density or to get in your little workout. And I think that's really cool.
And yeah, I love the definition of endocrinology that Dr. C has, where he says that he chose endocrinology because that's the nexus where physiology and lifestyle connect. Because, for example, if we think of something like type 2 diabetes, that was an aberration, or that was like the correct adaptation to a malenvironment. It's not a maladaptation. You're eating too much food, you're eating too much sugar, and eventually your body breaks. So that lifestyle connects to that disease process. And endocrinology is the medium that we need to fix to correct it. So it's not just giving someone metformin. It's correcting that lifestyle and maybe using different things to help with that correction in the short term. But in reality, what we're doing is we're trying to fix that underlying cause in order to prevent or reverse that disease. And that is just so cool. And then each one of us, we geek out on different things. And you have had a lot of exposure, or you have been on a lot of on social media and through your blog, talking about mental health. How do you connect mental health to endocrinology?
Firstly, mental health and mental wellness is part of everything. It's really incorporated into all aspects of our health. If you're not able to get up in the morning, and if you're not motivated to do things, and if you're super anxious and just going outside sets off this adrenaline and this fight or flight response, you're not going to want or be able to do other tasks that help you to be physically healthy, like meal preparation or doing little exercises, those little micro workouts. So in that respect, it really is critical to all aspects of health. But then as a more kind of concrete example, we have something like thyroid dysfunction, and we can see that some of the symptoms of thyroid dysfunction look a lot like some of the symptoms of depression. So you see several common features like cognitive dysfunction or brain fog, some slowing and some fatigue. And while not all patients with hypothyroidism have depression, and not all patients with depression have hypothyroidism, we do see that depression can occur in a hypothyroid state. And interestingly, it's not just that thyroid dysfunction that's impacting that, because even in a euthyroid state, some of those patients still experience depressive symptoms. And so researchers think that this might be due in part to that inflammatory, that autoimmune attack, which is really interesting. So there's a lot of overlap between mental health and endocrinology and any kind of other special field within health.
Cool. Okay, Morgan.
Yes.
So, we keep hearing all of this lifestyle. And sometimes we can think that, injection therapy, that's sexy. And it's only for people that are like sports, enthusiasts. But that's not the reality of the clinic. When I was doing injection therapy at the clinic with Dr. Inouye and Dr. Seenoth, we did see a bunch of people that were just bouncing around from doctor's office to doctor's office without any resolution. And then 3 injections later, they were perfectly fine. And one thing that I did learn from that PRC and the ability to have this completely integrative approach to pain was that A, not everyone needs opioids, and B, not everyone needs stem cells. Can you tell us a little bit about the difference between, like how we can get so, crazy excited about stem cells, and now everyone needs stem cells, but that's not the truth.
Absolutely. So one of the things that we try to talk to patients about when they first come into us is that, the lifestyle piece is so huge. We want to clean up their diet. We want to make sure that they're going to have the right micronutrients on board, so that when we do put in those strong workers, either the Prolo or the PRP or, the sexy stem cells, that they have a good framework to work off of. I had a patient my first year in the clinic that had come in wanting PRP in his knee because he had, reports from other friends that they had this and it was, the best thing ever. We got the majority of his results from putting him on an anti-inflammatory diet, and then did a little bit of Prolo on his MCL, and he was good to go. Doing minimally invasive work to just stimulate the body to do what it needs to do is really what we're all about at the end of the day. Stem cells, while they, like you said, they're a sexy kind of touchstone right now. It's invasive to go in there and harvest them. You're either tapping into someone's bone marrow or you're doing, in office liposuction procedure, both of which require extra healing time, and are kind of putting the body in a state where it's asking to heal not only the joint that you're looking to target, but also that place that you've harvested stem cells. And so I think that's really important to remember is, taking the patient to the level of healing that they are looking for, and they may not know what they're looking for right away. They come in with the keywords, and it's your job to investigate. Is this pain coming from an old MCL tear? Is it coming from that ACL surgery they had 20 years ago that never really healed correctly? And how do I best address that? And so that's a huge learning curve, I think, when you first start seeing patients, especially when you're in kind of the regenerative medicine or pain management kind of field.
And there's so many layers with this pain management thing, because like I've seen, like a bunion kind of reduce itself after a prolotherapy injection. Okay. And this patient had been coming, like every once in a while, oh, my bunion's acting up, and they would come in and they would have an injection. And then Dr. Van Dyke was like, you have really bad stance and your gait is all messed up. And he did a little bit of K-tape.
Change the person's world, right?
Correct. So it's using, how many times have we seen things like that happen with acupuncture or deep tissue massage? So why is it that you need to correct someone's like posture or, do massage or adjustments in order for these injections to work even better?
Well, you really have to look at the body as a kinetic chain. If a person is having pain in their knee, it's not necessarily coming from their knee. You need to be inspecting their ankle, their hip, and you need to keep going up that chain until you find a healthy, normally functioning joint. Then kind of work your way back and address the joints that aren't functioning correctly. Is it a muscular imbalance? Is it some sort of congenital bone issue where things are just not lining up properly? Is it the way they're sitting at work? Is it the way, their arches are falling when they're walking? And how is that affecting up and down the chain? And addressing kind of the main place, which may not be where they're having pain, but also, going in and providing the pain relief that they're looking for. We live in a very immediate satisfaction society, and making sure that patients are getting the results that they want and need with a mind frame of, where are we headed and why are we doing the things that we're doing? So patient education is huge in this whole thing.
So, we all agree that, even though we specialize in different things or, we have an interest to treat different disease processes. We all agree that diet is super important. We all agree that, sleep is super important, that stress management is super important. And then within that, we have really cool tools to help everyone get better. Like I remember when I moved from Florida to Arizona, I bought one of those pull-up bars that you put underneath the door frame, okay? and that was my workouts. I was just doing pull-ups at my friend's house, at my hotel rooms. I was just doing pull-ups. That was all I was doing. And then I couldn't feel my pinkies. Like after
How are
a while,
your shoulders? Yeah.
like I couldn't feel my pinkies, And I'm sitting there, first day, second quarter, Dr. King's class, and she was talking about thoracic outlet syndrome. And I was like, what? I have all those symptoms. So then I went to the training for the students, and I go up to Dr. Nick. Hey, Dr. Nick, I think I have thoracic outlet syndrome. And he was like, oh, you're full of shit. You are a medical student. You're probably just making this up because you hear it and you're a chronic hypochondriac. And he was like, no, I probably have it, So I sit down and they do, the testings, the physical test. And he's like, oh my God, you do have. He actually said, "Oh shit, you have it."
Sounds like Dr. Nick.
That's that. And he called over one of the TAs and was like, "Yeah, just his neck." And I was laying down, and then she goes, "Okay, move your pinky toe and crack, and then crack." And then I could feel feeling coming back to my pinkies right there and then. It was like, whoa. That's crazy. And what happened is that one of my circles was misaligned because I was an idiot, and I wasn't getting nervous connection to my pinkies. And all of a sudden, I was fixed. What would have happened had I gone to the conventional model? They would have said either one of two things: you're crazy, or never come back until you have something that we can prescribe you something. And I could have gone many, many, many years, and then I would have had, desiccation of one of my cervical discs, or maybe, bone on bone because of the misalignment. And I would have been miserable for 10 years until I was ready to do surgery. And that's what we're trying to avoid. And it's so silly that this medicine is so powerful and so accessible, and yet we still see some pushback.
We definitely see pushback. And you always get, people quoting, oh, well, my friend had Perlo and that's not a real thing. It doesn't work. In what environment were you doing it? Were you addressing the underlying causes of your pain, of your misalignment, of your degeneration? If you're not addressing those things, you can do all the injection therapies you want. You might see temporary relief and you might not. Another thing that you kind of touched on briefly before was kind of the mental emotional aspect. And I was actually going to quote Dr. Nick before, and it was funny that you brought him up, and I'm going to butcher this quote, I'm sure. Said something to the fact that the body will cry the tears that the eyes refuse to shed. And that's one of the things that I have had to learn with several of my patients is kind of, what is the body harboring? Why did you start having that musculoskeletal tension? Where's that coming from? Because you can chase it with a needle. If you're not addressing the underlying cause, it's going to manifest in another way. And I think that's something that's really overlooked with a lot of pain management, honestly. I think it was Justin Weiss who's getting ready to graduate.
Yeah.
You'll have him on next.
Yeah, I will. I totally will.
Recommended that I read a book by John Sarno and The Divided Mind, which is really just kind of guided me in a completely different way, and how I think about pain and how I think about some of the patients that undergo some therapies, see temporary relief, and then manifest in another, chronic pain sort of way. Which is a whole nother field, and it's really fascinating. And I don't know that we have time to go down that rabbit hole right now, but something that I just wanted to kind of touch on a little bit.
And, as amazing as this medicine is, sometimes it's not for everyone. We cannot, force people to change habits, but we can be damn good at explaining why. and Billy, you know, I'm pretty sure you see this over and over again, where you have people who have spent 50, 60 years with poor sleep and poor nutrition. How do you approach a patient that has never been exposed to our crazy ways, or to our, Dr. Midden is gonna yell at me, our hippie medicine, and actually like show them that, hey, this is how we function, and this is why we function. And if you could give us like a scientific, basis, maybe touching on evolutionary medicine, and a more like romantic or way of telling us, you know what, dummy, you need to eat clean.
Romantic. I'm not really a romantic guy, but I'll do my best. I just really sell it as good medicine. And we are physicians, we're doctors, we're trained as primary care deliverers of primary care agents. And I just tell people that we integrate the best of both worlds. I mean, we've touched upon the non-lifestyle therapies, and there's times that those are indicated, but we're really looking at the whole picture, and we start with less aggressive therapies first. And really, it's just, I mean, the wave is functional and integrative medicine, and that's really what naturopathic medicine is. We don't run around in leaf garments and loincloths and crazy stuff, and we're not hippies. We're physicians. We practice medicine. And so
we don't practice alternative medicine.
We don't practice alternative medicine. We practice good medicine.
Yes. Because there's two choices. There's medicine or not medicine. And if it's an alternative to medicine, that's not medicine. So we practice real, hardcore, successful medicine.
Yeah. I mean, I'm pulling up guidelines by the American Academy of Family Practice all the time, at least for the diagnostic sense, and then I'll deviate from there for treatment, because although I did come across an AAFP article for upper respiratory infections that mentioned Andrographis paniculata, echinacea, and zinc acetate lozenges. So we're creeping in there, man.
CMJ just shed a tear.
Wait, are you sure it wasn't zinc gluconate?
Yeah, I don't know, man, but not picolinate.
Yeah, exactly.
Never picolinate.
Maybe to rub on your skin, right, after weightlifting. Chris, when you watch this, sorry, man, no hard feelings. I guess a way to talk about this, and you kind of alluded to this when you were talking about endocrinology and diabetes, is, we don't have to get really scientific about it, but we're just looking at disease as sort of this adaptive process. Okay, so you come from what we call gametes or gametes from egg and sperm, and you're dealt a hand, like a card hand, and that's basically your genetic predispositions. And it's really fascinating how when you're put in an environment that we that came way quicker than we could evolve to adapt to, you have the expression of all of these different disease processes, whether that be diabetes, or arthritis, or lupus, or Hashimoto's thyroiditis, or MS, or I'm rattling off a bunch of autoimmune diseases here because I'm kind of biased, but these are all adaptive processes. And when we go back and look at that hand you were dealt and those specific cards, and we look at how we used to live when we did live in loincloths and things like that, all of these predispositions conferred typically some sort of benefit in the environment we came from and the selective pressures that we were subjected to in those environments. So, and it's us as naturopaths that really recognize this story written in those cards, and how, again, the selective pressures we have today cause those cards to express as they should, but it's just in a way that's not serving us with the environment we have today.
How would a overactive immune system be beneficial, though?
Well, there's a lot of reasons for that. So if you think about one of the miracles of modern medicine is that we don't really die from infectious disease anymore. Although, you guys have done a lot of work on that, and antibiotic resistance is something that's pretty scary and is a reality. But penicillin. The discovery of that just saved tons and tons of people. And these people who express this phenotype for a hypervigilant immune system are folks who are better protected from these pathogenic insults from the environment. Mostly women. A lot of these autoimmune diseases affect women, and women, the research is pretty, well, I can't say it's crystal clear, but there's a lot of epidemiologic and observational data showing that women are profoundly, they have a much more robust response to infections than men do, and it's likely because, women also have to bear a child to bring in the world. And then that's a whole different aspect that kind of makes the immune milieu kind of complex in the woman. The birthing of a child it's kind of gross saying this in a way, but a child is sort of a parasite, a foreign agent that the immune system has to surveillance and tolerate in a way different from mom's own tissues. So there's really a lot that goes into it there.
And basically, we used to live in environments where there wasn't chlorinated water and there wasn't any, we didn't have hand sanitizers, and we walked around, barefoot, and there was a lot of organisms that were trying to attack us. The more robust our immune system was, the less likely that we would die from infection. So then, fast forward with a snap of your fingers, the discovery of penicillin happens. All of a sudden, we don't have to fight infections because those infections can be now controlled with penicillin. And yet, our immune system is still thinking that we are under constant attack. So it goes rogue and it starts attacking you. Dr. Profrock talks about, like, one of his therapies for kids with autism is to go to the store and get one of those orange buckets, and 5-gallon buckets, and then go to your local organic grower and get some nice dirt and have the kids play in that dirt for 30 minutes every day.
Yeah, well, you've probably read this book. I forget the author's name, but it's called An Epidemic of Absence. And you've heard of the old friends hypothesis. And so you mentioned chlorine and, other means by which we heavily sterilize the environment. But I mean, basically, it's just lack of something that would distract
stimulus.
A stimulus that would tie up an overactive immune system, and it's really fascinating. And there's some clinics that are doing, and I don't know entirely how I feel about this, but they're doing inoculations with certain parasitic agents to regulate the immune system, and some of the findings have been really interesting.
Yeah, one of the I was driving home from work, and there was a segment on NPR talking about newly born C-section babies, and how they lack the passage through the vaginal canal and get inoculated with good bacteria. So there's a new study. It's going to be a double-blind placebo-controlled study where they are harvesting some of the beneficial bacteria from the mom, and then after the baby is born, they are inoculated with either that or water to see if having this inoculation is protected towards the kid. And I'm pretty sure we're going to get some really cool results out of that.
Yeah. So we're kind of getting into, again, like the one of the etiologic factors here. Definitely not a place to start. The basic stuff is really important first. And I always explain that to my patients. We're going to set the groundwork here. We're going to get all of the things that the body needs. We're going to remove all the obstacles. And if results aren't sufficient from there, then we can start looking at a lot of this exotic stuff.
Yeah, but the future is bright, and that's what.
Yes, yeah. There's a lot of answers, so you're not slated for, for some people the lifestyle stuff won't work. But that being said, you're not slated for drug therapy. There's a lot of stuff that's being investigated, and we're really at the forefront of that.
Tiffany, you mentioned that you started as a software engineer, and then you decided that you needed to do something a little bit different. Is there any difference or any similarities in the way you approach a patient's case as it is with software engineering, where you're looking for bugs and trying to get rid of them? How is that approach, and how have you observed that we are looking at this patients?
That's actually a really interesting perspective that I haven't really considered before. One of the things that I considered in switching from software engineering, or when I first began to feel like maybe this isn't the best fit for me, before I figured out what it was I did want to do, was that I didn't have any interaction with the end user. I was behind a computer. I was trying to learn programs from staying in class for 4 hours straight. I don't know who has a class for 4 hours on programming. It's really unfair. But working with a screen and a whole bunch of words and numbers, several different programming languages, I realized that each of us in that class were so isolated. And I really wanted to do something where I could interact with the person I was helping. And so when you have a patient in front of you, you have this really unique experience where you can work with them one-on-one to help them help themselves. You're not so much telling them what to do as showing them what's possible and inspiring change, or helping them to see what's possible in their life. So that whole experience also helped me realize the importance of social connection. And what I've really noticed in so many people, even in patients that come into the office, is that they're lacking that social connection. They've maybe moved in from out of state and they're starting new, or maybe they have a daughter or son who they're concerned about, and they might come in and say, I'm just really stressed right now. I'm really worried about my kid. They don't have any friends. They don't have anyone to do stuff with on the weekends. Or maybe they have lived here for a while, but they don't seem to have the support system that they really crave, and they don't really know how to get it. And I think that helping develop that is really important for health. That's a key component that is almost kind of overlooked because it's hard to address in a clinical setting.
We see it over and over and over. There was a bleep in the timeline where everything fell off, and everything, and it's not just going back and fixing that. It's not like, oh, I got into a car accident. You can't go back and prevent that car accident, or I broke my leg. Fixing that leg is not going to fix the endocrinology repercussions after that. And really going in and being a health detective and investigating. And then even, I love your analogy of having the end user in front of you. And then we, in our meetings and in our trainings, we're trying to debug the software. And that's where we spend hours upon hours trying to refine and modify. Maybe we don't need this supplement anymore because there's this other thing, or maybe this new paper says that probiotics are not as good as we thought they were, and then we can switch and modify things and debugging that software, and then we get to apply our programming with
we got to write new programs when needed.
and then we sit down and we see the results on the end user. So it's amazing.
And we give our patients the latest update, the latest upgrade. This version's now available, and then we give them little annoying reminders. In 30 days, here's your new labs, and here's your upgrade.
Yeah, no, it's fantastic. We're getting at the hour mark, and I know you guys are not busy anymore because you're not in school. But let's start backwards from where we started. Dr. Mitchell, where can people find you? How can people get in contact with you? Do you have a website, handles, interwebs, Musically links?
Oh yeah, Musically. Thanks a lot. Aaron Blydesdale would appreciate that.
I hope he's listening.
You can find me. My website is therobusthuman.com. So www.therobust, ROBUST, human, HUMAN.com. I have a blog and a podcast I maintain, and if you want to work with me, you can schedule appointments now through my website. I'm really active on Instagram. That's really the only social media platform that I put a bunch of time into. So there's content that's exclusive on my Instagram. It's Dr. Billy Mitchell, no spaces or underscores. Mitchell's with 2 L's, so at Dr. Billy Mitchell. And occasionally I post the podcasts on Facebook. And there's a Facebook page for a separate Facebook page for the practice, but I'm still working on that. So yeah, that's where you can find me.
Awesome. Dr. Massingdale.
So I am at the Pain Relief Center at the Southwest College of Naturopathic Medicine, soon to be the Neil Reardon Center of Regenerative Medicine. They keep promising us. I am not as socially media savvy as the rest of you. I don't maintain any online presence currently.
But
I
you will.
In the future.
In the near
I'll
future.
definitely throw that your way. But I am accepting private patients, and you can call and schedule at 480-422-1662. That is at the Pain Relief Center.
Awesome. Dr. Turner.
You can find me on Facebook or Instagram at Beyond 20 Questions. You can also find me at my website, beyond20questions.com, and you can submit Beyond 20 Questions there if you really have some questions for me. I love to dig around in the research. That's what I do, Saturday mornings, and also at Integrative Health in Scottsdale.
And you just had a really cool video from the Ancestral Health Symposium. Can you tell us just a quick snippet about it?
Yeah, so for the last Ancestral Health Symposium, I pursued a topic I'm super passionate about, and that's on, as you've heard, social connection. And the talk is called Broken Tribe, and it's the importance of social connection in depression. So I really investigated the literature and the research that we have available on that topic. And there's some kind of fun facts and maybe some surprising facts in there that might make you consider things from a new perspective. So go and check it out. You can find it on the homepage of my website.
Awesome. We're gonna, I'll make sure to put all the links, phone numbers, and so you guys can, if you want to work with any of these fantastic doctors, you can go ahead and schedule something, or maybe just a meet and greet. Super proud of you guys. The future of naturopathic medicine looks bright. It is amazing, to see how we're moving forward and how we can change people's lives. And we are down in the trenches, and sometimes, some days it gets kind of dark, and some days, you'll read something online, or, you'll someone will say something offhandedly, and you can get a little bit down on yourself. But in 1 year, when you guys look back at this interview, you guys are going to be so happy, and you're going to be so happy that more people are graduating and that more people are pushing our medicine, because it's not just the 80 people graduate with me, or I don't know how many people graduate with you guys, but family and friends and legislators and social media and our patients and super fans and all of these people that are requesting this true type of treatment, that are hungry for true health, people that are their own advocates and that are looking for the right answers. This is where the medicine is going. We are not fighting against MDs or DOs or chiros or acupuncturists. They are our allies, and we are an integral part in healthcare. So thank you so much for all you did, your efforts, your blood, sweat, and tears. And I can't wait to have you guys back once again in a couple of months, and we can update and have your own solo podcast and really, go out and kick some ass.
Thank you.
Sweet, man.
Thank
Sounds
you
good.
so much.
Thank you, guys. I'll talk to you soon.